My name is Michael Kontakis from the University Hospital of Uppsala in Sweden. Thank you, Guillaume and Marion, for involving me in this project. I'm going to be talking to you about the evolution of the number of extraforaminal cases in Montpellier here in the clinic of OrthoSud since the application of the introduction of the ESUBE technique. So the team is consists of Alexander, Mathieu, and Guillaume. How we what's this? Is it wait there? So as you know, open surgery for extraforaminal pathology, whether it is disc herniation or foraminal stenosis, can be cumbersome. However, with the ESUBE, we have the option of treating these pathologies endoscopically, and for some it might be easier to do so. So when it concerns the literature, there's not so much being said in regards to ESUBE versus open surgery. So if you have, for example, an extraforaminal disc herniation, you might want to treat it with a tubular microdiscectomy. Or you might do a ESUBE with a paraspinal approach, as Eduardo showed us on Thursday. It can also be found as extraforaminal, transforaminal approach in the literature. You focus on the pars. You have smaller incisions here, and you have also the obvious advantage of endoscopic surgery, which is that your eye is inside the wound in close proximity to the anatomical structures that are of interest, in contrast to the tubular surgery, when you have the significant constraint of having your eyes outside of surgery, of the surgical wound all the time. So this was a descriptive study, retrospective study of patients that were operated on in OrthoSud they had extraforaminal pathologies, and they were treated with extraforaminal approach. So from January 2019 until April 2022, all the patients they were treated on with the tubular surgery, and the ESUBE was introduced first in June 2022. Okay, so here you see the progression of the cases. For the tubular group, you see that the cases reach a plateau in March or April 2024 at 25 cases. Okay, and then for the ESUBE, we have now 77 patients, okay, of which 60 have extraforaminal disc herniations, 9 have foraminal stenosis, and 8 patients had both foraminal stenosis and disc herniations. And here you see the progress. I mean, here you see the percentage of the extraforaminal cases per year. And in 2022, you see a big increase in the amount of extraforaminal cases that were done, and this is when the ESUBE was introduced in OrthoSud here in Montpellier. Perhaps this new technique bolstered the confidence of the surgeons to do this, to treat more patients with extraforaminal pathologies. So here you see that the patients from the ESUBE group, they had a higher BMI, and there was also a trend for a higher ASA score. That means that the patients in the ESUBE group, they were sicker. And that means that the surgeon perhaps was more confident in this technique, and they tended also to include sicker patients in the treatment, which is good for the patient. For the preoperative data, we see that the ESUBE group had higher ODI, higher VAS score also. For the post-op data, at 1 year follow-up, we see that there was a trend for higher ODI change in the ESUBE group. Okay, this difference was not statistically significant. So if we have a visual depiction of the data, we see that a lot of patients from the ESUBE group, we have a lot of data missing actually, because they're not included in the follow-up yet. The follow-up is not complete, but we're going to have them, the data. So if we pull everything together with confidence intervals, we see that the ESUBE, the ODI in the ESUBE group follows the trend of the tubular group. So it decreases a lot with the months. And I want to remind you here that the ESUBE patients, they had higher ODI preoperatively, they were sicker, they were also heavier, and they do as well as the patients that were operated on with the tubes. And for the ODI difference, 3 months and 12 months, you see that difference was higher, alas, not statistically significant in the ESUBE group. Okay, same operative time, no dural tears, one hematoma that had to be washed out in the tubular group. That has to, in accordance also to what Carlos said in his presentation. But in the ESUBE group, we didn't have hematomas. We had 2 patients with peritoneal water diffusion and 1 hernia recurrence. So we see that ESUBE, even in the early stage, allows easier access to the extraforaminal hernias or stenosis. They have the patients have good clinical results, almost as good clinical results as the tubes, and has a low complication rate. So everyone should learn how to do it.
Any question?
No. Okay. Then we'll proceed to Dr. Ana Brito from Portugal. She will talk about the literature review of
I just think about something, because we mentioned 2 cases of water diffusion. It could be just impressive just after the surgery, because you see the patient with a big belly, but for the 2 patients there is no symptom with the diffusion, and the patient have discharge at D1 like habitually. Just to mention that you can observe that, but it's not a big deal. And to avoid that, you have to try to not to be too lateral, and try to stick to the bone. Just that.
You want to comment?
No, I'll do the presentation.
Oh, you'll do the presentation. Yes, of course.
Can I have one question? For the Dr. Vincent, you know, because you're a monoportal expert, what is your standing as a, you know, on a UBA conference, but from your perspective, if you're doing a transforaminal monoportal, and you get really inside the foramen, you know, and in some patients, especially on L4, L5, L5, S1, the foramen can be really wide, you know, and for the lateral recess and the foramen stenosis, you know, if you go with the monoportal, you can go really, really deep into the recess, and then you can go like from inside out, and you can use the both techniques, you know. With the monoportal, you can do the discectomy from the ventral side, and also you can do the foraminoplasty with the burr on the upper side, and then you can move outside, because from the biportal perspective, you go from the outside and you go in, you know, you do the chiseling and you work into the foramen. But from the monoportal perspective, you go outside. What is your take on the monoportal versus biportal transforaminal approach?
Yeah, that's an excellent question. Now, the transforaminal lateral recess decompression with the uniportal system works okay if you have a significant disc herniation associated with it. Like if it's a standard lateral recess stenosis with disc protrusion, hypertrophic facet joint, hypertrophic yellow ligament, then you're not usually effective enough to decompress that. Yeah. But if it's mainly or only the disc herniation, of course, that works fine. But it has to be really like a soft, fresh disc herniation, which you can remove to effectively create space. The instruments are not effective to remove disc protrusion. But the procedure itself, like a transforaminal lateral recess decompression, exists. That was one of the procedures shown earlier in that overview. But this is, in my opinion, something that only works in very selected cases. But a standard transforaminal approach, of course, works very well, as long as you said, the foramen is big enough.
Dimitri?